Cancer Care. I am Suzanne Stone. I'm the Chief Strategic Solutions Officer and Program Manager here at Livestrong. We are honored to have you join us for this really important conversation focused on the inequity in cancer care for the Black community. 43.5 million Americans identify as non-Hispanic, Black, or African American, making up 13% of the total US population. And yet collectively, Black Americans have the highest death rate and shortest survival of any racial or ethnic group in the US for most cancers. Today, we are not here to talk about best practices and what we're doing right now, but instead, this is a really unique opportunity to brainstorm real actionable solutions. So before we get started, I've got a few quick housekeeping items to go over. One that I already mentioned, please keep your video on. You are all muted, but you have the power to unmute, and we hope that you do. We want to see your smiling face, but we want to hear from you as well, because this is truly a conversation, not a webinar. There will be a short break, and right before we move to breakout sessions, so you will have time to take a break, so no worry there. Once we get into our breakout rooms, when you want to chime in, you can raise your hand by clicking the participant icon at the bottom of your screen, and then you'll see the little sign that says raise hand. It's at the bottom of the box that pops up. So just go ahead and click that, and your moderators will see it and be able to call on you. All right, well, I think we are ready. Tons of people in the room. This is so great. It is my privilege to introduce to you today our first speaker, Rhonda Smith. Rhonda is based in Los Angeles and is passionate about eliminating health disparities and driving change within underserved communities, specifically communities of color, to achieve health equity. She's led organizations like LifeServe Youth and Integrative Medicine for the Underserved. She's worked to transform healthcare delivery of FQHCs from a disease-focused model to a wellness one. She's worked with Susan G. Komen on their National Health Equitative Initiative to close the gap in access to high-quality breast care for Black women. Rhonda, please, you have the gallery.
So thank you. Thank you, Suzanne. I greatly appreciate the opportunity to be here today to share in this experience with you and to be part of a monumental event for Livestrong, a conversation on equity in cancer care for the African American community. Now, this hits close to home for me, not only because I'm African American, but more so because I've devoted my life's work over the last 10 years to addressing health disparities for the underserved and for communities of color. So I've been a witness to the structural and system inequities that exist that create the disparities gaps that we see. So I strongly believe that one of the key elements to making progress in closing the gap in achieving health equity is health literacy. And this can be done through patient education. And for me, patient education is something that most of us take for granted, but not everyone has access to reliable, evidence-based, and culturally appropriate health information. And this is essential, though, in promoting health in diverse populations. But how can this be in the age of Google? Well, unfortunately, not everyone has internet access at home, and this alone creates a gap in access to just basic information. Patient education is an important component in healthcare, and it is imperative that we recognize that poor outcomes are often the result of care disparities created by certain types of programs and services, or in some communities, a lack thereof. Now, over the past few months, we've heard a lot about poor outcomes in healthcare as it relates to COVID-19 in the African American community. And while COVID-19 has impacted the lives of many people around the world, in particular here in the US, it's brought to bear an important issue that we know has long existed: the inequities in healthcare and the impact that it has on health outcomes for the underserved community and communities of color, more specifically in the African American community. As of June 12, 2020, age-adjusted hospitalization rates are the highest among non-Hispanic American Indians and non-Hispanic Blacks. Non-Hispanic American Indians and non-Hispanic Blacks have a hospitalization rate approximately 5 times that of non-Hispanic whites, and Hispanics have a rate approximately 4 times that of non-Hispanic whites. Among those aged 45 to 54, African American and Hispanic COVID death rates have been at least 6 times higher than whites. And in every age category, African Americans are dying from COVID at a rate the same amount as those who are more than a decade older. Comparatively, African Americans have the highest death rate for almost all chronic diseases. And as it relates to cancer, African Americans often have lower or comparable incidence rates, but as Suzanne mentioned, have the shortest survival rate compared to most other racial or ethnic groups in the US. For example, African American men have lower 5-year survival rates for most cancers compared to non-Hispanic white men. And African American men are twice as likely to die from prostate cancer compared to non-Hispanic white men. And African American women are just as likely to be diagnosed with breast cancer as white women. However, they are almost 40 times more likely to die from it. And African American women are twice as likely to be diagnosed with stomach cancer, but more than two times as likely to die from it compared to non-Hispanic white women. Some of these causes for the differences stem from demographic factors such as race, socioeconomic status, gender identity, where people live, and immigration status. These factors, or social determinants of health, create barriers that prevent access to quality, equitable cancer care. The result leads to a gap in cancer outcomes, but we must call out these inequities as a public health issue. And we must ensure that there's equitable cancer care for everyone. Now, equitable cancer care means that individuals, regardless of the color of their skin and what they look like, where they live, how much money they make, or what country they come from, receive high quality, life-saving care in a bias-free system. Equitable cancer care is truly patient-centered care, and every patient receives the individualized care and treatment that they need in a timely, efficacious manner. But that doesn't happen for everyone. For decades, the African American community has suffered the greatest health disparities. And although there has been some progress made in closing the gap, African Americans still remain at the top of the list for health disparities across the board. And now, amid the COVID-19 pandemic and the Black Lives Matter movement, we have reached a tipping point, a point where inequities are no longer acceptable for anyone. So now is the time for us to come together in unity to solve this problem and to begin to close the disparities gap. So we must work together to address the inequities and dismantle the barriers so that we can improve cancer outcomes for African Americans and for all people of color. So I am here today to do my part and take action to ensure that there is equity for all, not only in cancer care, but in healthcare in general. And I challenge you all to do the same. So I hope you've had some time to give some thought to the Mad Libs and the what if statements as part of your preparation for today. And as a reminder, ICON EQ is about 3 things. Number 1, focusing on innovative problem solving. So how do we solve the problem of disparities in cancer care for African Americans and address the challenges of patient education in this community? And number 2, bringing stakeholders together in this space to have bold conversations, discover the most innovative solutions, and explore the big what ifs in a way that will enable us to gather information from a diverse group of people and learn how we can think differently about problem solving. And 3, reimagining, reinventing, and creating new ideas and approaches to close the disparities gap and in patient education for the African American community by examining what is happening and why, and examining ourselves and what role we can all play in ensuring equitable cancer care. So we hope that ICON EQ will be a unique opportunity for you to ask the right questions, solve the right problem, provide innovative solutions, and make an impact. We hope that when you leave today, you will have an idea, or maybe two, and an action plan for how you can and will affect change in your work, your community, and your life that will lead to greater health equity for all. Thank you, and have fun.
Thank you, Rhonda, so much for setting the stage for some really great conversations ahead. Next, I want to introduce all of you to your moderators for today and allow you to get to know them just a little bit before you break out into your rooms. So I'm going to give you a short summary of who they are first, and then I'm going to let them share their Mad Libs and what if exercises with you. First is Dr. Lelia Noel. She is currently a visiting faculty fellow at the University of Texas at Austin School of Social Work. Her research focus is on the social and economic conditions that contribute to lower cancer treatment utilization and higher mortality rates in marginalized communities, particularly those of color, and within residentially segregated urban and rural neighborhoods. Dr. Noel.
All right, so I wanted to also say that I am currently a research fellow at the Livestrong Cancer Institute here at the University of Texas at Austin, as well as the Hogg Foundation for Mental Health. And in the fall, I will be an assistant professor on a tenure track at DUT. So we'll be working on some health equity issues in Central Texas moving forward. My Mad Lib I wrote, I really like what Rhonda said earlier. My research actually kind of parallels Rhonda's through the Midwest, but my Mad Lib was interesting because the first part of it asked, when did cancer become a part of our world? And I thought that was interesting. So I'm just gonna read it first. Cancer became a part of my life in 1995 when I started working for the American Cancer Society on the south side of Chicago, following my master's at University of Chicago. This was my first exposure to a gap this was my first exposure to the gap in health equity that exists. Since then, I have worked as a social science researcher in New York City, St. Louis, Missouri, and now here in Central Texas. Cancer has touched my life personally as well. My mother has survived 2 diagnoses of breast cancer 15 years apart, the latest of which is this past year, so we're just finishing radiation. When I think about progress in cancer care today to solve the equity gap, I feel encouraged. What I find most challenging in relation to cancer patient education for the underserved and uninsured today is finding ways for healthcare organizations to build community trust in partnership with communities. So I'm interested in finding a way to continue to bring a diverse group of partners together to advance health equity efforts within our community. Livestrong can help me by 1, being a partner with communities towards such efforts, and 2, supporting efforts that empower communities to advance the work within their community. And I think we'll deal with the what ifs in breakout, if that's okay.
Absolutely, absolutely. Thank you, Dr. Noel. So next is Sharon Ricks. Sharon is the Director of Health Equity Strategy and Transformation at the Dell Medical School at the University of Texas at Austin. Prior to leading this effort at Dell Med, she was responsible for leading and coordinating internal and external health equity strategies for the United States Department of Health and Human Services. Sharon, will you share your Mad Libs?
Good afternoon. And yes, I will share my Mad Libs. So cancer became a part of my life this Sunday at 2:35 p.m. I got a text and later a voicemail from my older sister. And she only said 4 words, "Can you call me?" By the time I called her, it was 5:48 p.m. But before I tell you what she told me, I want you to know what an amazing woman she is. My sister went to Ivy League colleges and for undergraduate and graduate and became a lawyer and had the best federal career a person could have in the federal government. And all of our family was very, very proud of her. In fact, the first time I heard the N-word hollered at our family was when we went to her graduation in New Haven, Connecticut. So, and our father fought back. And I was scared. I wanted him to be quiet, but he was so proud of us as a family. And so she is an amazing woman, and she's always taking care of her health. Every year she gets a mammogram. So she called me to tell me she has stage 0 breast cancer and that she has to get a lumpectomy and radiation. And as she's talking, my mind is like crazy because this isn't supposed to be, this isn't supposed to happen, not to families like us, not to people like her. And I always wanted to believe this is something that happens to other people, that we're somehow protected and we don't have to worry about those things. And yet here I am on this phone and hearing her tell me, yes, it happens even to people like me, even to people who get mammograms every single year and do everything they can to be healthy. And so I would like to say that I am entering this meeting full of energy and full of emotion and so ready to hit the ground with real ideas. I feel like stories from people you trust is the most powerful motivator out there. After hearing her story, after knowing that it touches my family, I feel like there's no excuse for personally me not getting my mammogram every year. There's no excuse for me not reaching out to other sisters who might think they're invincible like I did. And we have to use those stories in order to move people and to leverage the power in those stories to change lives. So I'm really excited to talk about patient education in a breakout session, whoever's in the session with me, and to hear your ideas about how we can do that in a way that will be most powerful and most impactful for our communities. So thanks for having me.
Thank you so much, Sharon. Okay, so I think most of you should have received our pre-event Mad Libs exercise that Sharon and Dr. Noel just went through. So, and thank you to everybody who took the time to fill them out and return them to us. It really helps us build the breakout rooms. So we're gonna have a quick break before we split up into our conversation rooms. And during that time, if you haven't had a chance to do your Mad Libs exercise, I'm gonna share my screen so that you can do it now. If you have already done it, please track yours down because you may want to use it in your conversation today. Your break, our break is going to be just 4 minutes. So ask Siri or Alexa to set a timer and I will see you back in just 4 minutes. Welcome back. I do hope you did get a chance to do your Mad Libs and what ifs, and you do have them handy. So we are going to split up into 2 breakout rooms. Remember, if you, I'm going to assume everybody is really familiar with Zoom by now. So if you choose gallery view, which is in your, the view choices in your upper right-hand corner, if you choose gallery view, then you're going to be able to see most of the people who are joining today. So remember to use the raise your hand feature when you want to chime in. If you are calling instead of dialing in from a computer, then just go ahead and speak. We can't wait to hear you. The room is going to be open for 45 minutes. As a reminder, you've got that 5-minute alert prior to close. So you're going to see that. You'll see a timer at the top of the screen to kind of help guide you as well. Please have a wonderful conversation. We're really looking forward to hearing your solutions, and we will see you in 45 minutes. So Brittany, who is the master computer wizard, is going to break us all out. So go for it, Brittany. We'll see you back in 45.
What I want to hear from you, everybody has a story, and I know everybody has a sense of what the biggest challenges are, what the biggest problems are related to the equity gap around cancer care and prevention. So if anyone would like to be first, I would love to hear your thoughts about the biggest challenges. And I will call on people, so.
I'll go ahead and share since I know KK and I am going to meet Sylvie this Friday. We haven't met, but we've talked on LinkedIn and we connected on LinkedIn. So wanted to just let people know that's a really great platform for connecting with people who have the same interest. My area of interest is plain language, in particular, as how it affects disparities. You know, the data shows that when people have low health literacy, they actually are less likely to stay quit when they take a smoking, you know, quit smoking cessation program. They're less likely to do preventive care. And it's not because they don't understand. Sometimes it's because what we say as experts are so incomprehensible. And we need to remember that. And there are definitely techniques and tips and strategies for speaking in a way that is meaningful and that is relevant and that is compelling to our audiences. And as experts, we need to speak in that way and not like experts. So that's my issue and my passion.
Lynn, thank you so much for that. So many times people misunderstand health literacy, thinking people don't understand, when really sometimes the person doesn't understand the audience. The audience isn't as understood as they need to be. So I really appreciate you talking about it in that way, and I agree with you. That's a big issue. Any other big challenges folks see out there? Plain language is definitely one of them. Melanie or Sylvie?
Actually, I'm going to have to jump off, so I'll go really quickly.
Oh, good. Okay.
You're doing a great job, by the way.
Thank you.
I feel like it's what we don't know is the biggest problem. And I'll even take it a little further, is unconscious prejudice. You know, that I think this is probably the biggest issue, is that in being in a more privileged community, sometimes we don't even know what we don't know in terms of what's happening. I'm the CEO of Make-A-Wish, and we are working really hard to reach out to underserved communities, but sometimes not knowing even how to get better at it is really a challenge. And I think a lot of that has to do with our organizations, that we need to build more diversity into our organizations so that we can know what we don't know. Yeah.
I love that. It's almost like you need a mediator, like somebody who knows the audience to help you get in, the warm introduction, and help you to understand better.
Mm-hmm. Yeah, and you need that consciousness all the time in the organization. You know, you just need to really build much more diversity and engagement in the organization itself.
Yeah. Well, I'm glad you joined, and I'm sorry you have to leave early.
I know.
But I love your thought about unconscious prejudice. That's really good. And then your solution about how to fix that. Yeah. Melanie, how are you down there?
I'm good, thank you. I am the CEO of an organization called Cancer Care Services, and we provide financial and emotional support for cancer patients, caregivers, and survivors. And I wish more people knew how many resources were really out there to help, that people really felt cared for, and our vulnerable populations realized that there really are agencies and people who are so committed to filling gaps and that they knew that we existed. We could do a lot more than we're doing, but people just don't know that we're here and that we exist for them.
Yeah, that is so important too. Not only knowing what the information says, but where to get it, who to talk to, and who can you trust, and are you going to be welcome and embraced? I always think about, like, even if I knew where to go, would I be too scared to call? Would I feel like they have something for me, or so it's interesting. Even when you have the information and they know where you are, do they feel like you're home for them too? So that's really good. Juliet, how's it going down there?
Pretty good. So I'm a temporary care navigator at Shanti, and I got my degree in women and gender studies. So I have a really big passion about adjusting language, especially for younger patients in the LGBTQ community. A lot of the times when they go into doctor's appointments, it'll use their birth name instead of their preferred name, and they could immediately feel discouraged and disconnected from the doctor just off of that. But for me, cancer came into my life when I was about in 3rd grade. My grandmother was diagnosed, so I've always been kind of aware of it. But she's in Southern California, so they didn't have that many resources at the time. So I've always had a big passion about helping, especially she's Hispanic, so in Spanish speaking. So there is a lack of understanding, and it was hard for her to remember everything that the doctor would say. She would come out of the appointment and it would have been gone. So it really motivated me to get into this type of work and kind of make sure that people can remember everything and just have someone there to support them along the way.
Yeah, and do you think that when it hits a family, then that family is more educated than, well, I guess obviously they are, like, because you were in 3rd grade, like your whole life has kind of.
It was and it wasn't, because I was never taught, even though she was diagnosed with breast cancer fairly young, I was never taught how to give self-exams. It was nothing we really talked about. Okay. And then later on, when I was 19, I actually discovered a lump in my breast. So that was another eye-opening thing for me of, oh, okay, this is something that can happen to me at 19 instead of when I'm older. So especially for a younger woman, I feel like it's something we don't think about. Even if cancer is in our family, I was never taught, and I know for my family, when my grandmother was going through it, they chose to take care of her themselves. They thought, we knew her better, we'll take care of her at home, which I think is definitely a cultural theme. So it's good to see, but yeah.
Wow. So we got 6 more minutes to talk about problems, and I'm itching to talk about solutions, because as you guys are talking about problems, I'm thinking about, like, messages for young people, messages for Hispanic people, messages for people who don't know what resources to go to. Like, how do we make sure everybody feels included in the education that we give? So I'm excited to get there, but we have to give 5 more minutes. Anyone else, maybe I can't see you because you're not on my screen or you're on the phone, but you have a big challenge and you haven't heard it yet. I'm gonna pause and let you holler.
I'd be willing to share what I think a issue is. I think sometimes it's accessibility on many levels, not just physical accessibility, but I think accessibility to knowledge and resources at the level that you're comfortable with. I am the director of a blood cancer foundation in Michigan, and I actually was diagnosed with leukemia when I was 19. So I have firsthand experience of, having gone through it. And I realized when I was first diagnosed, they spoke to me differently than they spoke to my parents. So when I would ask questions, they would turn and direct the answer to my parents rather than to me. And they spoke to me like I was a child, and I often felt talked down to, and it made me resistant to ask more questions. And I realized they probably do this to a lot of people, that, you know, they may not even be aware that they're doing it, but, you know, I felt like, you know, why are you treating me like you know, I'm not an intelligent person, even though I was just 19. You know, I feel like there's probably a lot of people that, you know, the language that's being shared with them, I think like, was it Lynn that had mentioned, it's just on a different level. And I felt like then those answers were no longer accessible to me because I wasn't talking to somebody who's going to treat me like I felt like I needed to be treated.
Yeah, it's almost like you don't want to talk to me, so maybe I'm not supposed to talk to you either. You know, it's just like you block the communication potential right there.
It was a very easy way to get me to stop asking questions.
Gosh, that's horrible. Wow. Thank you. I know someone else hollered out.
Yeah.
We still have.
Hi, I'm Aimee. I work within the same organization as Juliet. A lot of us are community care navigators, and part of our role is to accompany clients to their medical appointments. And I certainly echo what Melissa had said, that we do witness in medical appointments where the providers, sometimes if the patient don't speak the language, they don't speak English, and they get talked over. And I think one of the challenges that you mentioned, you had asked before, I feel that would be engaging the patient in the process of their treatment, making decisions, and building that trust. I think if the trust is already broken in a room where with the doctor supposed to treat them, it's really hard for the patient to stay engaged and continue any sort of engagement to treatment or adherence to treatment, or even have access to, or believe that they have access to the education that they should know from their diagnosis.
I'm so glad you brought up trust. To me, that's almost like the foundation of patient education is trust. And I just want to ask you a follow-up question. Did you feel that accompanying patients helped to increase trust, like sitting with them?
Well, maybe because I'm biased in the role that I work in.
Maybe I should ask Juliet.
But we do, well, I also accompany patients in their appointment, and feel that, and before we do that, we actually had met with the patient before, and we developed some sort of relationship or trust with them, and then accompany them to those appointments. And as someone who is not in the medical community, being with them, if they, you know, it gives them some, I feel that it gives them some confidence to advocate for them, or by that point, most of the time we may know our patient a little bit better, and if we see that they're not really engaging in a conversation, or they may have some question marks in their head, you know, being their advocate in that space, it's really important.
Yeah. Yes, Juliet.
Just to add on that, I haven't I haven't done any accompaniments, but I have had discussions with clients who have, and a lot of the times some of these clients don't have anyone to go to their appointments with. So it helps them to have that support, knowing someone's going to be there when they get out, and they're going to make sure that they're okay. And also just being an extra set of ears to get everything, because sometimes when the doctor's talking, you're not going to catch everything. You walk out and you go, okay, what does that mean? So it really helps for them, I think, because they'll say, yeah, I completely forgot about that. I didn't even remember that he said I have an appointment next week for my post-op. You know, just they're focusing on one major thing. So I think it's really beneficial in creating a trust system, because they know there's more people to back them up.
That is so awesome. I remember my husband has kidney failure, and he doesn't remember anything they say in those appointments. If I'm not there, it's over. So definitely having somebody who's listening while you're processing and while you're grieving, somebody who's able to help you walk that path is so important. So we are done with challenges. But think about those challenges that we just heard, and I'll go through them. Plain language, unconscious prejudice, wish people knew about resources. Accessibility, remembering the doctor's instructions, talking to the patient as though they're a child, and accompanying and building trust. Think about all of that, and then put on your craziest, wildest idea hat. I don't care what it costs. I don't care what it would take. Like, if we could do anything, and we can. Look at all these CEOs listening. We can. Anything, the thing you wish people would just start doing, this is the time to throw that idea out there. 30 seconds of here's what I'm thinking, and then we'll drill down on it together. You don't have to have all the answers, but just the idea. So I want to start with my crazy idea while you guys are thinking. And I was thinking about like a PSA series or something. My background is journalism, so I really love stories. I mean, people's stories drive you to action like nothing else. People being their authentic selves is amazing. So I was thinking about how can we take the stories of people like the 19-year-old with cancer, the African-American light skin and dark skin, rich and poor, educated and less educated, all those stories in one place, and have some kind of way for them to be shared. I was thinking like 12 stories or whatever. And maybe somebody will say that's already been done. I don't know. But I just feel like I know that's what's going to make me go get mine, is that I realize it's real. And the only way it feels real to me is if I know a real story of somebody else that's walking through it. That's my crazy idea. I'm going to ask, anyone else have any crazy ideas? And I will call on you. And I haven't heard from Sylvie Leotin yet. So, and Carlton Allen and Dina Jansen. Any ideas on how we can address some of the challenges? I also thought about a woman of color, like 800 number, like just for us, like here's a number you can call where you'll be understood. You'll be embraced. You can relax and let your hair down, take off your wig, be you, and just talk and get answers to your questions. Maybe that's crazy too, but just anything that makes people feel like they're welcome to learn more.
So I'll tell you mine.
Okay.
So my crazy idea is, what if we've already seen some work done like in salons and at churches, right? Or barbershops. And so like, what if we ramp that up? Like in the barbershop is the doctor's office, or in the salon is a mammography machine. Like, in the church is a screening place, because you're there those are places that are that true community center. So what if instead of having doctor's offices in traditional doctor's offices, what if we start putting our doctor's offices in the places where the community actually goes? Instead of asking the community to come to us, we go to them. And you can go get your hair cut and get a mammogram or your blood work, or even just like the regular checkup, just general health in the place where the community is. So that's my big idea.
I love it, because you're talking about putting it in the place where people already feel supported, so, and they can see their sisters using this, and it's not like some odd thing where you have to step out of your world and to get this done. No, it's in your world and it's normal and people do it. And maybe even having some advocates around, champions around that look like you, encouraging you to use this resource that's in your comfort, supportive community. That's awesome.
Yeah. We got to hear more. I know you guys did your statements.
I'm going to take a drink while somebody talks.
Sharon, I'll follow up on your idea for a PSA of patient stories. One of my good friends, I'm originally from Portland, Oregon, actually called me this weekend to just check in. It's COVID time, want to make sure everyone's doing okay. And we were talking about the Black Lives Matters movement and how there's this push for us all to read these nonfiction novels to educate ourselves about what this community is going through. And her and I were like, there's this big pressure to like read all this information and digest it, and somehow we'll become experts. And we both acknowledged that that is not what would work for us. And we said that we would learn more by reading fiction and hearing about these narratives about the actual experience that people of color go through. And I know there's a lot of great books out about that right now. So I just wanted to say that I agree a PSA of stories would be super helpful. I also encourage our volunteers, our Live Strong leaders and champions, to always lead with their story, because I think it sets a great stage for explaining what people really go through when they go through cancer. So I'll comment on that, and I'm still noodling on a wonky solution, but I may chime back in.
Awesome, awesome. Well, we still have time, so I know the great solutions are going to come. Sylvie Leotin, I see you down there. What's going on in your brain? I can't hear you. Are you muted?
Sorry. Okay, I'm muted now. Okay. Hi, Sharon.
Hi.
Hi, everybody. Yes, I'm actually the CEO of a company called Health Equity Lab, and I'm just starting. I'm a cancer survivor, woman of color. I notice I'm the only person of color in this room. That's kind of disappointing, but I'm here representing brothers and sisters. And I've been really distraught by all the racial disparity as a survivor and a woman of color. So I'm starting a company to address this. And I'm coming from a completely different field. I've been working in technology innovation for 20 years. So I'm bringing wacky thinking that's not used in clinical research to bring new solutions. But I really liked your idea and what KK said. Yes, I think that stories are very important. I think that the gap is really coming from something that it's hard to understand if you're actually not African American. You know, there are things that you can observe from the outside, but you cannot see them from the inside. And, you know, I've experienced this very painfully in my cancer journey, not just because of my skin color, but just being a cancer patient, no one understands you. It's just painful. I'm writing a blog that's like super famous just because I'm writing about this, and people are like, wow, you're really talking about the emotional experience of cancer, like no one has ever spoken about it. And so when you add this to being a minority and, you know, all of those different things, I feel that there is really a need for insider voices. I think that's the only way to actually bridge the gap, is to be able to bring what's felt inside on the outside so people can see it, feel it, experience it, and not just read statistics. So I completely, I'm in agreement with the stories and the narratives, but I think that the research has to be made by African American. Like, I've read so many things on health disparities, and it's great, but it's very superficial.
Yeah, I love that you do a blog. That's a great another way to communicate. And when you said technology, I started thinking about apps. And I was like, well, how can we use apps? Is there a cool app we can make?
Yeah, I'll be building apps. I'll use augmented reality, virtual reality, everything. Avatar. I'm really excited to get into this. So.
Like a day in the life of, and you put on these glasses and you get to experience what it's like to be a Black woman with cancer or whatever it is.
That's what's needed, because, you know, we can spend all this money to try to solve the thing, but unless we really understand it from the inside, we're not going to build solutions that are really deeply going to be resonating. And you know, my background is doing this in technology to really understand the human and psychological needs of customers.
Yeah.
You know, what they look like.
I'm looking at Carlton. Did somebody else say something?
Oh, yes.
Carlton, how are you?
Doing well. Thank you for asking.
Good. Any big ideas? Or small ideas?
Yeah, I've been trying to think, and I don't know if I have any big ideas, but some of the most I think successful patient education strategies that I've come across with, and I'm a program director at a health science center in East Texas, and so a lot of our population is in rural areas, and sorry if you hear any background noise. I'm working from home today, so.
Is that a Great Dane?
But some of the most successful strategies have been ones that have been interactive in some way. They've educated the population where they're at, and so in the community, and then this was someone that's been trusted, or an organization that's been trusted.
That is so awesome, because that's what Suzanne was saying about going to that barbershop, into that hair salon, maybe the nail salon.
Yeah.
And in that community where they trust the people there. Hi, baby. Everybody say hi.
Yeah. I mainly work, or a lot of my work has to do with colorectal cancer. And I always say that different sort of than breast cancer and lung cancer is most people know what to do, and you know, they know that smoking causes lung cancer. They know that they should get their mammogram for breast cancer. And so with colorectal cancer, we kind of have to do a pre-education and really tell them what this is and how they should be screened before anything. And so one of the strategies that we have is we have a giant inflatable colon that we take out in the community, and it always gets a lot of attention, but it's a pretty proactive and pretty responsive educational tool that we use.
Awesome. Keith Peterson, I see your name.
I know Cassie has her hand raised.
Oh, Kathy.
Yeah. Hey, Cassie.
Hi.
Cassie,
Hey,
yes.
Sharon.
Hey.
Well, it's interesting because I was thinking something similarly along the lines of a forum or a place where perhaps like diverse perspectives and points of view, voices can be raised, marginalized voices where they could tell their stories and be able to post them to some sort of forum. And then I was thinking on the app lines as well. So could there be an app similar to a dating or matchmaking app where you could go on and there would be people that you could connect with and message with, and maybe there's a section of people who are willing to be advocates with you, and maybe they can't come to your appointment in person, but you can have them on FaceTime or you can have them on Zoom, and they're with you at that appointment. If someone's has someone in their physical proximity, at least having someone virtually to remove those barriers. Because I know a lot of people, I think, and I can only speak from my own experience, which is, you know, I'm learning a lot and I recognize I have a lot to learn, but I know that sometimes you don't feel comfortable sharing this type of information with your personal network because you don't want to deal with their opinions or your mom nagging you, have you made that appointment or have you gone to do that checkup? And so it's easier just to not talk about it. So having someone outside of your regular circle that you can maybe have more of a candid relationship with, and not without the fear of either judgment or opinions, or just kind of always being that's all that you talk about with your loved ones.
Right.
You know, kind of having that bipartisan, outside connection might be helpful for some, because I do see people that tend to not bring up things because they just don't want to have someone kind of pestering them about it all the time, if that makes sense.
That is so cool. I would love to see an app like that.
What if we combined like all of this? This is my favorite kind of stuff. So what if we took the virtual reality piece that Sylvie was talking about, and we combined it with the stories that you and KK are talking about, and educated the way that Carlton is talking about, but we had that trust factor. We could build the trust factor. So if we create the story, the virtual story, it's a day in the life of, right? Because you're talking about that, right? Like, because there's no way I could possibly know. So if we create this virtual day in the life of whatever that is, maybe it's a patient who has cancer or whatever it is, and as you're sitting in the barber chair, you've got a virtual reality glasses on, and that's what you're experiencing during your 30 minutes sitting there, or if you're a female, it's way longer than that, right? You've got a few stories, you've got time for a couple stories at least, but maybe that's real, like that would be so eye-opening to have that real experience and have it related to health somehow. Have it related to cancer, and whether it was prevention or survivorship or whatever, that could be really interesting, maybe. Okay, so that's
I love it. Everything is loved. We love them all.
Yeah, and Suzanne, this is Cassie. So I was thinking, like, we could have an app where you could upload your story, and I could look through profiles and see, like, oh, this person's also going through, whatever type of cancer experience or journey, and maybe I open up a chat with them and talk to them about their experience, and they look like me, or they, maybe I find out they live in my community, but we didn't know each other, or, like having that's where that matchmaking, I think, could be really interesting, to create a dialogue with people that you can build a relationship with, that you can relate to.
I see all those things already exist. There are just tons of things like this for cancer patients. I think maybe you have to be a cancer patient to be aware of them. But, there are really tons of websites and apps and virtual things that are built like this.
Are they focused on particular communities like we're speaking of, or are they broader?
There are some things that are starting for particular communities as well.
Great. That's where I definitely see that obviously there's some potential based on the feedback we've heard today. So.
Yeah.
I think this goes back to the previous commenter's observation that there's so many resources out and we're not aware of them. One of the things that I've been talking with a few people and we'd like to see happen is to start what we're calling community conversations. And this will be, of course, done virtually on a platform like Zoom, where we would invite an expert on something. And one of what we're focusing on is the social determinants of health, these things that unless you address them, we're not going to be able to reduce any disparities in cancer or any diseases or any health issues, because they're so broad and global and pandemics. And so we would invite some expert in some particular area. It could be water quality, it could be, some air quality, it could be vaccinations, whatever, but we'll invite an expert to speak and then have those, the audience attend virtually, where they can have conversations. And at the end of the expert's conversation, we would have resources available. So there, what we've seen is when we do stuff with the community, that there's usually two audiences, and you have to think about those. I mean, one audience is a learner. They want to learn things, they want to understand more. And then there's another audience that are the activists. They want to do things. And so we want to be able to have information available. So, okay, so you realize, oh, this is really exciting to me. I'm very excited. I'd like to do something. So we'll have resources available for those people that can participate if they want to, and already have this kind of community and partner with people. This conversation kind of came about because I was talking to some of my friends on Facebook, and they felt very hopeless and helpless because all of the news, and they felt like they couldn't do anything. But they also felt guilty because they're doing well. They're not, you know, the group that is at risk. They can work from home. We know we're very lucky. We know that we don't have to be out there serving customers, wiping tables, interacting with people. So they just want to do something, but, you know, marching isn't their thing. Or they want to know who else is interested in this with me. I don't want to do something by myself. I want to do it with others. So we thought this might be a really good opportunity for people to connect, just like what we're doing here, and learn about something new. And there's things that we can do if we choose to at the end of this conversation.
I love it. I could see a series of community conversations, and people could kind of get a peek into this community and communities you would never imagine, like coming together to talk about this issue, and let the experts hear, you know, some of the reality pieces that that they experience in real life. Because sometimes I think what experts present and what real communities experience aren't even lined up too well. And back to the resources, I know there are resources out there, but is there something we could do, like focus test those resources? Like send me the survey, or send somebody the survey and ask, what are these questions? Do they work for you? Is there a better question that we should be asking people like you or your family that we're missing because we don't even know to ask the question? So I would say we need to challenge ourselves too, that even if we have resources, are they working? Are they the best? Can we tweak them? Can we make them better? Can we put them out there more? How can we help promote each other's resources? So just, all of that just went through my head. But I love the community conversation idea. Yes.
I just want to jump on the resources too. I think one thing is that even though the resources may be there, it's maybe a challenge for patients to fill out the paperwork, follow up with the paperwork, follow up with the resources, and actually, you know, be able to go from the start, you know, accessing that resource and actually receiving the support at the end. I often see like a drop in the middle. And so again, my push will also be as a community advocates to come in and pick up, be the safety net and pick up that piece. And one other thing that I was thinking about is when we look at pamphlets related to cancer, it's really wordy. It's very jargony. So it'll be really nice to see like a really simple infographic, because there are patients who may not know, you know, they come in different languages and stuff. And so like having visual, it might be tricky to pare down really scientific stuff into simple visual, but it would be really nice to see something like that available for communities.
That is so good. Especially when I've never been diagnosed with cancer, but I can't imagine trying to figure out what resource I need when I'm dealing with this crazy news. I can't even think. So having an advocate to me is key, even to help you sift through resources and know what might help you.
So I want to second what Aimee said, because so at MD Anderson, we have a program that patients can apply for to get the care covered if they meet certain financial criteria. And, you know, for a long time, then this was years ago, but for a long time, we had very low applications, and it seemed like it was, gosh, you would think they would want to come in, and even we have physicians working at a local public hospital. So our physicians are working there and they want to transfer these patients over to MD Anderson for clinical trials or whatever. But when you give them the paperwork, it never gets completed and nothing gets processed until the paperwork's completed. So when we had a committee and we looked at the paperwork and we were asking way too much information and the details, and we didn't, like, you know, we had to really kind of push back at the institution. Just because you've always asked this, do you need to do this? And can we make this form easier to look at for someone who might be low health literate, have problems reading, etc. So we made it a much shorter form, and now we're getting much more applications for financial support, and we're bringing in different patients.
Yes, I second that, Lynn. As a cancer patient, I can tell you that everything that we get thrown out, you know, is really hard to understand. You know, I have personally a lot of degrees and I'm more educated than most cancer patients. But as I was going through cancer, I was like, my God, I need a PhD to actually, you know, because I have all this knowledge, I can go through it. You know, making the decision on your treatment is the hardest decision for a cancer patient. And anyway, I did some research and I found what I needed, and I went to my oncologist and I knew already what I should get, which was great. But then I went and looked at that same document that was supposedly patient focused. So they knew that it was complicated, and so they had made a simple version for patient. And I go and look at the simple version for patient, and yes, it has pretty images, but it's just as illegible, you know? And so that's really a big barrier, Lynn.
Yeah, I mean, if my 88-year-old mom can't understand it, it's not good enough. And we're not testing this stuff on people's 88-year-old moms.
Yes, but what I'm telling you is even me with all my
right.
I struggle. So it's just like, oh my goodness, imagine.
Yeah, and then put on top of that, you've been diagnosed with cancer. So I can't even imagine focusing, you know. We've got about 3 minutes. So if there is someone who hasn't had a chance to talk, please do. Don't let this moment pass. Carlton Allen, Keith Peterson, Christina Pale, Dina Jansen. Christina's on. I think. Christina, did you have anything? Okay. Well, I won't push it. But I feel like we did try really hard to address some of the challenges. We've got some great ideas here. And we could really do some stuff. And even if the idea is imperfect, it's a start, you know?
Absolutely. Thank you for being brave and speaking.
Yeah.
Sorry, could we maybe then get a list of everyone on this group's emails, and then we can send out, and so kind of having our own little group here so that we can share emails and ideas and have conversation.
Absolutely, and I'm going to talk about that when we get all back into the main group. But we will all get everybody's email, and this will not be the last Icon EQ. So we hope to continue to build off of each one, and you know, maybe that's narrow in focus, and that's why we're looking for these great ideas, so we can kind of see which ones come up to the top, what are the challenges that really come up to the top, and convene those people that are really focused on maybe just that one space. So yes, you will definitely have a chance to collaborate with one another again. And this will not be the last IconEQ. Maybe next time we'll have it in the morning or maybe at night. Maybe we'll get to travel sometime. We can go somewhere new. But yes, absolutely.
Okay. Well, I don't want to end early because we didn't really get a warning about the time.
We did. We did.
Oh, did we?
We did. You were just
focused. Oh, okay.
We're focused. Yep, we're about 37 seconds away.
Yay. Okay. I really enjoyed talking to you guys. I feel like we're all here in my little one-bedroom apartment, just getting to know each other. So good to see you guys. And I guess when we go back in the room, we'll be mixed up with everybody.
Absolutely. So you guys can click the leave room button, or you can just wait and Brittany will hit the button for us and we'll all zoom off.
All right. Cool.
See you in the main room.
Okay.
So I'm interested in finding a way to better collaborate and coordinate across providers and leaders. Livestrong can help me by being part of the solution ecosystem. Do you want me to stop there, or do you want me to do my what ifs also?
Why don't we stop there and just do the what if? Let's just do the Mad Libs first and then start talking solutions. In the ideal world, does that sound like a plan with everyone? I'm moderator, but I'm supposed to be facilitating a conversation amongst you wonderful people. So jump in if you have other ideas. Thank you, Susan. Let's go. I'm going to go in order then with Scott Joy, I think is next on my screen.
All right. Let's see. Cancer became a part of my life in 2003 when I was diagnosed with testicular cancer, and even more so in 2013 when my wife died from multiple myeloma. When I think about progress in cancer care today to solve the equity gap, I feel troubled by the gap's size and persistence, but glad it's receiving needed attention. What I find most challenging in relation to cancer patient education for the underserved and uninsured today is lack of trust that everyone is acting in the patient's best interest. So I'm interested in finding a way to make health systems trustworthy. Livestrong can help me by fostering connections that build knowledge and share human experience in new ways.
Thank you, Scott. Joanne, is it Bursch? How do you say that last name?
I get myself off mute. Hi, I'm Joanne Bursich. Nice to meet you all.
Nice to meet you.
And one of my colleagues is here. This is a little bit different for me. It's not quite what I expected. I'm actually our Vice President of Administration at Living Beyond Breast Cancer. So I participate in part of a cancer health organization, but this is kind of new to me. So I did do my Mad Lib, and I'm happy to share it. Cancer became part of my life in 2000 when I met my now husband and learned about his history with Hodgkin's disease. When I think about progress in cancer today to solve the equity gap, I feel confused. I find most challenging in relation to cancer patient education for the underserved is that the health insurance system is so complicated. So I'm interested in finding ways to advocate for a simpler health insurance system and health insurance for everyone. And Livestrong can help me by pointing me in the right direction to learn about advocacy efforts.
Mm-hmm. Good, thank you. Heidi Grix. Did I say that right?
You said it right.
Good.
As long as we're in the United States. Good afternoon, everybody. I'll read this, but maybe talk a little bit off the cuff too. I became aware of cancer. It became a part of my life when I was in my early teens and my grandmother was dying from breast cancer. I have a long history of cancers in my family, and have been working not necessarily in the direct healthcare space as a nonprofit executive for many years, but in organizations that support healthcare, support families to ensure that they're getting everything that they need, to ensure that what's not covered by healthcare, there's a safety net under them so they don't fall through the cracks. And I have found over the last many years that I'm optimistic because I'm a nonprofit professional. I have to say that when I think about the cancer care situation today, and that where that gap is and how wide it is. I'm optimistic because I work for a nonprofit and we're here to solve problems, right? I'd like to echo the things that each of you has said. Healthcare is way too complicated. I feel that it is set up to oppress. I feel that so many of the things that I'm working to solve as a nonprofit executive are solving little pieces of an oppression system that has been set up and growing and growing and growing and growing for many, many generations. And we are reaping the benefits of it today. And I think that with the current movements in our society by racialized populations, that we have a chance to really make change. But I feel like we're doing it little pieces at a time, and it needs to be a big holistic move, and I'm hoping that's what's happening now. So I think that's how Livestrong could help me. I honestly feel I'd love to put my organization out of business. I'd love to make sure that every person who is diagnosed with cancer, it doesn't matter where they come from, what color they are, or how they're raised, that they get the service and the support that they need. And we don't need nonprofit organizations to pop up to make sure that there's a safety net.
Thanks, Heidi. Thank you. I'm taking notes because as you're talking, my mind, I'm a professor. There's so many things I want to say, and I'm trying not to interrupt you. So I'm just jotting down. But I do want to just mention that I think one of the things you said was the point of intervention, I think might be something we talk about after everyone shares their lips. Thank you, Heidi. Tracy, want to unmute? You're on mute, Tracy. Yeah, there you go.
Hi, I'm happy to be here. Cancer became a part of my life when my aunt was diagnosed with ovarian cancer about 4 years ago. She was able to live another 2 years, and it just really impacted my life, losing such a close, relative, someone who practically raised me. And so when I think about progress in cancer care today, I feel pretty optimistic. I feel like, we do have a big group of community that want to make a change. But I also feel like I find it challenging in today that, I don't think it's a priority until it's too late. I feel like, it doesn't get the attention that it deserves, considering how many people are affected as compared to many other diseases and causes of death. And so I am interested in finding a way to, to educate and to become more involved and to be more involved in the community to help others. And I think Livestrong is the perfect place to connect people and to support the people that actually want to make a change.
Great. Thanks, Tracy.
Thank you.
Nice to meet you.
Nice to meet you too.
Linda Burns. Hello.
Hi, Layla.
How are you? It's good to see you.
Cancer became a part of my life. I think it was about 1999. My mom was diagnosed with stage 3 colon cancer, and she died about 3 years later. And so I would, take her to her appointments sometimes, and I saw how she deteriorated over time. So it was a very moving time for me. And I had no lens to see to know about disparities as far as in healthcare as it relates to Blacks with cancer. So I had no measurement there. And I never, tell you the truth, never gave it much thought until joining the Department of Health Equity and having so much focus on the disparities. as far as my Mad Libs, I said that I feel optimistic. I think that so much has happened over time to shed more light on this issue, and so I feel very optimistic that we're talking about it, and I feel like that something is being done, and even more will be done in the future. I think that as far as most challenging, I think there's a huge slack, especially in the Black community, compliance. You know, we put off and we put off because there's something else going on in our lives. We feel like there's something, we have other things that are more pressing or that we have to worry about. And so we're not always compliant. I myself have put off my mammogram because of all this pandemic. I kept saying that's something that can wait. And I haven't done it yet, but I will, because I go every year. But I think that that's a big issue in our community, and that, you know, that we have proper screening. I think that also increased awareness would be a way to, you know, to bring this forward and to help in those issues. I was a member of a big church in Houston, and they had this fundraiser every year, and the whole focus of that, the group was called, led by the minister's wife, Charmingly Pink. And she had a big fundraiser every year to raise money, and this was donated just to provide transportation for people to get back and forth to their appointments and to assist them in that way. I was very impressed with that, because I could see that, you know, something was being done, and that was a big issue, and especially in our communities. So.
Good. Thanks very much. I also need to confess I haven't had my mammogram either because of COVID-19. And my mother, you too, Heidi? Yeah. And my mother is currently finishing her second round of breast cancer. I see a couple more hands. Yeah, it's a little confusing as to what's considered, elected. Yeah, elected, and what's not. There's an education for us, Rhonda, right there. It's like, just in general, I worked with Dell Medical School, and I'm confused on what's elective service and what's not. So I think being able to communicate, finding avenues to communicate to communities and working with communities to get those messages out, I think are maybe something we talk about today. Thanks, Linda, appreciate that. And let's see, Susan's already shared with us. Mario Rodriguez. Hi. You're on mute. Unmute yourselves. There you go.
There I go. Hi, Layla. Hello, everybody. My name is Mario Rodriguez, or if you can roll your R's, you can say Rodriguez. Either way.
I try.
So I'm really excited to be here today, and I have to say that, you know, cancer became part of my life probably a couple of years back. Had a couple of uncles with cancer, but really 2 years ago when I started my role, I worked for a healthcare organization called Roche. It's a Swiss company, and it has deep roots in oncology. And what I do is I help multidisciplinary care teams with technologies that help them make decisions, hopefully better decisions, for treating patients with cancer. And I was new to cancer. I'm a healthcare professional. That's my background. And I've been in healthcare for 20 years, but oncology was just not one of my areas. And coming into Roche, I got to see everything from screening and diagnosis all the way through treatment and on to survivorship. And literally, I got to spend at Baylor University in their path lab, seeing those tumors getting grossed and analyzed. And and then sitting at tumor board, you know, multidisciplinary conferences where you have oncologists, pathologists coming together, and radiologists, and just really making a treatment decision based on consensus of how to best treat these patients. But then hearing them talk through the whole patient story, you know, case by case, and doing this every week, it just really has impacted me so much, because even though these uncles of mine have had cancer, I have to confess that they're not very close to me. So emotionally, I wasn't really feeling it. But when I sit there at these meetings with these clinicians as they're making these decisions, and I hear the stories of the patients, and I actually see their cancer live right on a screen, it's just like, wow, you know. So anyway, I feel that, you know, personally, so that's my story with how I came into cancer. I feel very optimistic, right, about how to solve the equity gap. And I think that one of the most challenging parts is about cancer patient education is the lack of awareness and resources and technologies that can bridge gaps and disparities amongst minorities regarding clinical trials, multidisciplinary care. And I think really that, you know, one of the biggest challenges is cancer is a very complex disease. And doing what I do now, I see how much data is generated by a single patient, and having a clinician. I'm from South Texas, down in the valley, right? Where, and for those of you not from Texas, the valley is like that southernmost tip that borders Mexico. So resources are really limited down there. And a lot of times patients, they don't get to have their cancer reviewed by a multidisciplinary team. So it could just be one clinician that's guiding the whole treatment, and that patient is really trusting his entire care on just what's in that physician's mind. And with so much information, it's hard to leverage all this information, and really, sometimes it can be difficult to make the best decisions for the patient. So anyways, I can go on and on. We'll cover more regarding the solution, but I'm interested in finding a way to link the African American communities to solutions that, where I work with, resources that are there, and Livestrong can help me gain a better understanding of its role with the patient's care continuum, and any goals or initiatives on leveraging technologies to help patients.
Great. Thanks, Mario. Greg, you have your Mad Lib handy.
I do. First of all, thank you, Dr. Noel, Sharon, and Rhonda for part of this conversation today. Cancer has now been a part of my life 4 different times. The first time 43 years ago when I was first diagnosed with malignant melanoma while a sophomore at the University of Texas. Again in 2018 with a recurrence, and then followed up with another recurrence back just in the fall of last year, right before the holidays. Most recently with breast cancer diagnosis of my wife last year, followed up with some cancerous polyps on her colon just a few weeks ago. In fact, a week ago yesterday, I was in surgery in North Austin to have 5 cancerous polyps removed from her. So this is very, very near and dear to me. In terms of my Mad Lib, when I think about the cancer care, the progress being made to solve the equity gap, I'm like Susan Dawson expressed earlier, I'm both frustrated because there's not enough action that's been taken. But I'm optimistic that I hope that the veil has been broken on these inequities. I do believe that there's much more awareness that is necessary. I think that awareness needs to include a very emotional element and a very emotional appeal to strike a chord with people. I don't think the facts alone will get their attention. It is downright wrong that the inequities exist and that the access to care is limited, and that your success with a cancer diagnosis is more reflective of where you live and your ethnicity than having open access to care like it should be. That's just a moral and ethical issue that we have to get by. I will also share with this personally with this group. I'm a 3-time cancer survivor, but as you can tell from your screen, I am a white Caucasian male. And although I understand cancer from my perspective, I have no idea, and I cannot claim to have any feel for what that means for a Black American. I have no understanding. I know the frustration that I go through, but quite frankly, I've had a very privileged experience. Mm-hmm. And so my eyes are wide open, my ears are wide open, and I know as an officer of Livestrong, I'm doing every damn thing I can every day to try to improve that access to care for people, because it is a moral and ethical dilemma. This is just not what's good or bad for business or anything else. This is a moral and ethical dilemma that needs to be solved. Mm-hmm. And so I'm optimistic that there has been a veil broken. I think this is a step along the way to where we have these conversations, but there is more that is required. And I'll have a chance to talk to the group a little bit later, so I'll save some of that. But I'm excited to be here today, and I appreciate y'all being here to share your thoughts and ideas and recommendations on solutions for us.
Thank you so much for all of that. Again, I have a lot up here, but in essence of time, I will keep it moving to, is it Erin? Is that correct?
Yes. Yeah, Erin. Hi, everyone.
Hi, Erin.
So I'm Erin. I'm with Living Beyond Breast Cancer. I'm our Director of Outreach. So I think cancer became a part of my life. I think I was around age 22 when I lost both an aunt from colon cancer and an uncle from lung cancer, all within the same year. And so that's, I think, the first part. When I think of the progress in cancer care today to solve the equity gap, I feel both optimistic and pessimistic. So the optimistic part is that I am really excited to see this energy and conversation and focus on this in a new, and hopefully a new and different way. Mm-hmm. And I feel like it's gotten out of the inner circles of some cancer conversations and spread out. So I'm really excited about that. The pessimistic part is I'm really worried about the budget crisis and kind of how that's impacting nonprofits, healthcare systems, and how that's ultimately going to take away supportive care services from cancer patients, and how that is really going to impact the quality of life of people undergoing treatments, the delays in potential treatment, diagnosis that we may see as the impact of the pandemic. So I'm really bracing and really worried about that. And I think that we will unfortunately see that being played out in equity. Those impacts are going to, unfortunately, I think, be felt differently by different communities. And
correct. Yeah.
Not really worried about that. So what I find most challenging in relation to cancer patient education for underserved and uninsured is, I think getting the information to the people that need it most is very challenging. It's something that I'm working on with my position every day. How to build trust and get the information and the education out there is really challenging. And I think ways that I'm interested, or a potential solution, I would love to see sort of more services in many different areas. So community-based interventions in the cancer centers, in the health systems, and religious settings. Someone mentioned churches earlier. Really broad-based approach to getting that education and support to where people can easily access it without those barriers.
Great, thank you. Liana, how are you?
Hi, thank you.
Hi, thank you. Would you like to share yours, Madeleine, with us?
Yeah, I'm Leanna Levine Reisner, and cancer became a part of my life really when I was a young child, and my grandmother decided to tell me and my cousins about the fact that she was one-breasted and what that meant for her, and it was very clearly something that played on her mind every day of her life. But later it returned to me when I was in college, and my mother was diagnosed with non-Hodgkin's lymphoma, a very aggressive T-cell lymphoma, and she managed to survive it, but it took a great toll on her body and on the family. So, when I think about progress in cancer care today, I actually feel somewhat bewildered because since then I've become aware of lifestyle factors, and specifically nutrition and food, as substantially, just hugely important in the development of cancer and in its progression. And so what I find most challenging in relation to cancer patient education, not only for the underserved and uninsured, but for everybody, is how the lowest tech approach, which would be nutrition, is so underappreciated. So I'm interested in finding a way to bring hope with a food as medicine approach. And I think Livestrong can help me and my colleagues by giving a platform for lifestyle-based solutions to both cancer prevention and cancer survivorship. Because, so many times I come into conversations about cancer and nobody talks about food. They're talking about the next drug trial or the next, surgical innovation. And we know more than that. There's a lot more evidence than that. So that's what inspires me.
Good. Hold on to those ideas. Those sound like the kind of creative ideas that Livestrong might be looking for when we get to the second part of our question. Thank you. Adrienne Manas?
Yes.
Did I say it?
Manis
somewhere?
is fine.
Manis, okay. Hi.
So for my Mad Lib, cancer became a part of my life. I think I was 15, possibly 16, when my mother was diagnosed with breast cancer. She's actually right here, Susan Dawson, wave.
Oh, really? That's neat.
Different last name, same family.
Yeah, she's downstairs.
Did I meet you at the meeting? Never mind. Sorry, we only have
totally
we only have a little time left. I won't digress.
And then after her having further metastasis of that cancer, when I think about progress in cancer care today, solve the equity gap, I feel a little disappointed that it's taken this long to even get this far, but also optimistic that a lot of people are focusing on it and putting all their effort towards it. And then what I find most challenging in relation to cancer patient education is making sure that a lot of the information and education that people get is correct. Because as good as the internet is for spreading information, it also can definitely lead people down a rabbit hole that might get them in more trouble than they were originally in. As well as the fact that there are still people that sort of refuse to acknowledge that there's a problem with cancer equity, or at least think that if it doesn't affect them, they don't have to do anything about it. And then so I'm interested in sort of finding a way to make more people aware and make sure that the spread of cancer education is correct and that people are getting the right information that they need, and that Livestrong can help me by bringing people together like this so we can come up with ideas that help everyone from no matter what background they're from.
So that's awesome. I'm just being reminded by our wonderful note taker on the time, and I want to, we still have about 4 or 5 more people to go through Mad Libs on, and I want to give us enough time to get to solutions, which is the whole point of this. So I'm going to maybe try and speed us along just a little bit, but give those last 5 people time to maybe start with solutions but go backwards so they have time to talk maybe. And because I want to give us time to get to solutions, because a lot of wonderful things have been said and I don't want to cut anyone short at all. So but I do want you to know that we have 15 minutes left in our time together, which went really fast, I feel like. So I'm going to keep going real quick. Sanford James, you are next. And I know you sent an email to everyone, but do you want to share your Mad Lib or do you want me to read it? Can you hear us or reply? Maybe he can't hear us. So if you're muted, if you're trying to speak. All right, I'm going to go ahead and read what he wrote real quick, and then we'll move on just in case. He says that I am curious to know if the current public health crisis has uncovered some systematic racism policies that have continued to widen the gaps. There remains significant mistrust of the healthcare system. How much energy has been spent in the community not talking at the community? Many marginalized groups have strong ideas about equity, but are not asked. There is too much top-down philosophy. So that is where Dr. James is coming from. Victoria, you probably, I don't know, do you want to share or should I keep going? You probably type something. If you want to share, send me a message, Victoria, I'll keep going. Mia, Victoria, do you want to share?
I can share. Yeah, I'm
okay.
a note taker. I've been taking notes from everyone
yes.
that's been speaking and things. But
Thank
I'll
you.
just run through. I know we are short on time, so maybe I can run through my Mad Lib, and then I'm sure there are some great solutions out there that people want to suggest. So I've got two screens here, so I'm going to read from the other screen. So cancer became a part of my life in 2012 when we actually moved to Texas to join Livestrong. I say we because my husband first started working at Livestrong back in 2012. And as you can tell by my accent, I'm not from here. And his suggestion was like, do you want to move to Texas to join, the Cancer Foundation and be part of the great work they're doing? So like, sure, let's do that. Anyway, fast forward, I'm now working full-time at Livestrong. So it's great to be part of the team, and so that's when we joined Livestrong. And when I think about the progress in cancer care today to solve the equity gap, I kind of feel like a mixed paradox. I'm positive, I think, and grateful for like the American healthcare system and the services and everything that's available. But also fearful and frustrated. I think the comparison between like the English National Health Service and then the American, I think all healthcare systems are, have their positive and negatives. So I think it is mixed feelings, but what I find most challenging in relation to cancer patient education for the underserved and underinsured today, and it's been echoed, I think, is that, navigating the healthcare system and the insurance system. I mean, as Greg said, I'm white and female and fortunate enough to be fully employed and have health insurance through Livestrong, but it's a bit of a nightmare trying to navigate the system and to get the services you need. And that's from me. I feel like I'm privileged in that sense. So that's what I do find challenging. So I'm interested in finding ways to streamline and simplify the system. And I think Livestrong can help me by continuing to provide the support for all cancer patients and survivors, and to partner with other organizations doing the great work across the community, especially those serving marginalized communities.
Sounds great, thank you. So here's what we're gonna do, because there's 10 minutes left and I have been a horrible facilitator in not, I guess I underestimated how much time it would take for all of us to get through our Mad Libs. And I apologize for that. And I don't want to be rude to those people who haven't had a chance to share. If what I'm going to do, I'm going to move us a little bit towards solutions, but Mia and is it Srini, if I'm pronouncing it right? There's a couple people on the phone, Maria. If you guys want to share your Mad Libs when we talk about solutions, please feel free to do that. I just feel like with 10 minutes left, I don't want you guys to walk away without anything in your toolbox. I want you to at least have a couple things in your toolbox. And I hope that we'll be able to come back together as a whole group to continue this conversation, because I think it's going to take us a lot more time to come up with solutions and to collaborate together to move forward. But at least this is a start of conversation. So in essence of I'm feeling very rude only because I feel like everybody should have a voice at the table. I'm a collaborator, and I apologize to those of you who didn't get to go, but there's 10 minutes left, so I want us to at least have something on our paper by way of what our group feels could be like in an ideal world. What would it look like? But jump in if you want to add anything that hasn't been said from your Mad Libs, and I apologize for cutting the intro short. The second part of our sheet that Livestrong gave us is the what if statement. And the problem we are focusing on for our conversation will be the lack of cancer patient education for the African American community and the ultimate impact it has on cancer patient outcomes. If all things were possible, which means equity wasn't, inequity wasn't an issue, and all barriers were removed, which could prevent success, what is your solution? So think of it this way. We want to know, like, for right now, we want you to think outside the box. We want you to think about if we were looking at an equitable system of care, if we were looking at those things that you guys have talked about, where health insurance we know health insurance is confusing. So how do we get the information into the people's hands in a way that they can receive it? You've talked a little bit about, compliance and being, what are some of the barriers that people have to being able to go for their screenings and being compliant. We talked about issues of how people are perceived by the medical community based on race and SES, access to information and resources. And I was going to say, when Scott was talking about resources, and is it a matter of a lack of resources, or maybe it actually was someone that was maybe Mario saying that it might have been lack of resources. Is it a matter of lack of resources, or is it a lack of information on where to go get those resources? Connections. Is it the system where there's breaks in the system to getting the information in a way that people can receive it and want to receive it? Again, like Sanford said earlier, speaking with, working with communities, not at communities. So how do we do a better job of actually including the community at the table and finding out what the barriers are for that community, and how do we? So does anyone have any wonderful ideas that they'd like to throw out there? Victoria's taking notes for us. Somebody speaking? Oh, Rhonda's trying to speak. Okay. You need to unmute your, okay. There we go.
Got it. Yeah, so I want to first of all thank everybody for all the great comments that were made today. It really, I really appreciate it. And so for me, what I heard a lot of people talk about was things that could be done at the individual level. And so for me, I look at, health disparities is a very complex issue. And I look at it at three different levels. There's the individual level, the community level, and the system level. And I think all too often we focus on the individual and community level, but not so much at the system level, right? And so, decisions get made in a certain way for, whatever reason. And I guess for me, getting at the root cause of the problem, or why disparities exist in the first place, is going to be an important success factor going forward. So I think at the system level, when it comes to the system itself and providers who are part of that system, there may be, there's a couple of aspects. One is around health literacy. And for me, that works both ways, right? So there's health literacy that can be improved at the patient level, but there's also health literacy that could be improved from a provider perspective, right? So I think that would be a good marriage. And then also, as part of that, there is a lot of unconscious bias or implicit bias that exists. So I think addressing that I'm not quite sure how, but I think addressing that will start to get to the root cause of some of the reasons why disparities exist, or different patients get treated, in different ways, unfortunately.
Yeah.
And then the last thing I wanted to say, if someone mentioned this earlier, is about technology-enabled solutions. So, so even when we talk about underserved communities and communities of color where folks may not have internet access at home or computers at home, most have mobile phones, which are smartphones. And so how can we have a greater connection between the provider, the system, and the patient to help with navigation, with help with patient communication, and that whole patient-provider relationship. And I think that can happen through technology-enabled solutions. So that's my 2 cents worth.
Rhonda, other than bias in the system, what do you mean by health literacy for providers?
Yeah, so when I look at health literacy, whether it's cultural humility, cultural competency, or really, taking the time to understand about an individual patient. So, a lot of things may happen to an individual before they show up to an appointment to see a healthcare provider. And I know within the way the system of care works, there's a limited amount of time that a provider has with a patient. But through things like motivational interviewing or, other approaches to, maybe whole person care, I think just taking the time to understand more about that individual patient improves the health literacy of the provider who's caring for that patient. And then understanding, more about that person's background from a cultural perspective, an individual perspective, even where they live. People often go home to a food desert, right? So you can't, as a provider, say, you need to have better nutrition habits or eat more fruits and vegetables. But when they go home to a food desert, there's no access to that. Right. So just being aware that, for me, that's part of the health literacy from a provider standpoint. So hopefully that answers your question. Okay.
Yeah, I think, Heidi, are you raising your hand or?
I always have something to say, so I'll apologize for that. But I want to capitalize or maybe continue that thread with the thought, just going home to a food desert. So then there's an organization that has to step in and figure out how to get food to that family so that that need is fulfilled. It's to go back to your comment about the 3 levels of function. It's that highest level where the decisions are made and the disparities begin, and it travels to the other 3 levels, and on that individual level, it's reinforced over and over and over again, because this is where we're creating the safety net. And so we're reinforcing the inequities even by existing to help people. Mm-hmm. And I know that sounds a little odd, so I apologize for that. It's a little backwards.
I just, if I may.
Yes, hi.
I just wanted to, hi. Sorry, I'm on my mobile phone, so hopefully you can see me okay. I'm Srini, and as a technologist, just to right on Rhonda's comments, when I see a problem, my brain is kind of wired to start thinking about solutions and fixing the status quo. And this often gets me in trouble with my wife, who asks me to only listen to her problems and not try to fix it. But towards that end, I did want to say that I'm actually the founder of a company called 80/20. And what we realized is there's no single place for patients to go to see what good outcomes look like. So, what survivors did before their treatment, what they did during their treatment, and what they did after their treatment. So there's really a lot of unstructured information out there, and we're hoping to kind of solve that through our app. So I did want to just to mention to Rhonda's comment that there are people who are trying to solve this problem and bring more equitable care to patients everywhere.
Thank you for that. We have 1 minute before they're going to automatically boot us back to the larger group. And so in that 1 minute, I would like to just say that I'm sorry we didn't have enough time to really dig into solutions. I really do apologize for that. I'm grateful that every single one of you came today to start this conversation. And I really do hope that Suzanne will have a second meeting so that we can delve into solutions and spend the 45 minutes literally talking about where do we go from here and how do we partner with our communities to really start to address the health equity issues that we have in our area. I appreciate everyone being here because your presence alone says that you recognize that there are health inequities out there and that you want to help. So I want to say that in the 30 seconds that we have. And again, my apologies. So 20 seconds left. If you can say it in 15 seconds. Otherwise, I hope to be back here with you having this conversation so that we can get straight to solutions. And I apologize we didn't do that today.
Go Live Strong. There.
Go Live Strong. It's a good starting point.
Thank you for moderating, for sure.
Let's see how many we have. All right. I think we've got everybody back. So we're gonna, so in your breakout rooms, first, thank you for being so brave. In your breakout rooms was at least one Livestrong staff member who was taking notes. And so I want to share, since we couldn't all be in one room because that was way too many people, I wanted to share some of the ideas that we came out with. So the first was challenges, and challenges, it's interesting looking at the notes across both rooms and very similar things. We heard that you feel confused, that we need to do a better job of understanding our audience, that we have this chance to really make a change, but we're doing it little pieces at a time, and that there needs to be a big change. We heard about looking for ways to provide financial and emotional support for people who are affected by cancer. Messages for young people as well, and that we're not doing a great job of talking to young people the way that they need to be heard. Also that, that people are disappointed that it's taken this long to get this far, and that access to care is not just a moral dilemma, it's an ethical dilemma that needs to be solved. So a lot of great, great feedback there, and we appreciate that. So when it comes to solutions, I definitely want to talk about what some of our what if moments were in the rooms. So we had one idea of what if there was a woman of color 1-800 number for those who get diagnosed with cancer, a PSA series with a lot of stories. Another idea is technology-enabled solutions. So how do we better connect patients and providers? And if a provider says, eat more fruit and vegetables, but the patient goes home to a food desert, how can we solve for that? Another solution that we heard was around a virtual reality experience, so that those people who are not in the African American community can understand what it's actually like. It's like a day in the life story, and making it in that virtual reality version. So those are just some of the great solutions that you guys came up with. And again, thank you for being brave, and thank you for sharing your big what if moments. A couple of things before I introduce our CEO and president. So one question that we always get at ICON is, we've made some great connections and I really want to continue to talk to everybody. So don't worry, you're all going to be able to be connected. After ICON, after we're finished today, in the next day or so, you're going to receive a few things from us. You're going to receive a survey. So we definitely want you to fill that out for us. You're also, though, going to receive an email list for everybody who is here and participated in the room today, so that you're going to be able to stay connected with them and to keep those conversations going. But you should also know that we're going to do a highlight reel, and we'll have a recording available to everybody here as well. So you can go back and listen if you want to, when you run, if you run out of Netflix. But then also, this isn't the last ICON EQ, it's just the first. So be sure to look for future ICON EQs, Equity in Cancer Care, as we continue to drill down and look for really innovative solutions to this problem. So thank you all for joining us today. But before we go, our president and CEO, Greg Lee of Livestrong, has a few final thoughts. Greg?
Thank you, Suzanne. I had a chance in the breakout room that I was in to talk a little bit. But first of all, I just want to acknowledge and thank Dr. Noel, Rhonda Smith, Sharon Ricks for the opportunity to participate and be a part of this, for us, what will be a kind of a recurring theme and recurring opportunity. I'm also fortunate to have two of those three right here in Austin, Texas. And so Sharon and Lelia, it is my commitment to find a way to get together soon as best we can amidst this pandemic, to be able to visit and talk about what we're doing together. Obviously, as an organization, we have been involved in the creation of the Livestrong Cancer Institutes to really revolutionize the way care is delivered. But also we realize that person-centered care is a vital part of that. And as we've heard today, we all know the statistics now. There's 43.5 million Americans who identify as non-Hispanic, Black, or African American, which is 13% of our U.S. population. And as Suzanne talked about earlier, we know that right now Black Americans have the highest death rate and shortest survival rate of any racial or ethnic group in the U.S., and this has to change. We also know that amongst the surveys that we've conducted here at Livestrong, overwhelmingly the highest selected item and rated item was patient education as the primary gap in care. And so we are going to continue to use methods like ICON EQ today and other mechanisms to better understand what that patient education gap is all about, and begin to try to bring around change. We know that this issue at hand is systemic and it's long-standing. And it requires a solution and a response that's both systemic and long-term or long-standing as well. The problem is that dialogue alone is not going to solve this. Words are important, and they're important beginning, but action is much, much more important than just words. And so we are committed, as you may well have known, we've committed publicly to annually spend money addressing these gaps. We have solution grants programs that we are implementing. Most recently, Suzanne and her team announced north of $500,000 a year that is being devoted to solutions to address practical problems. We are committed to continuing those solution grant programs to try to address the practical needs that we all face in cancer care, but specifically the underserved and underinsured communities and the Black community specifically. We really appreciate you being here today. We want you to be part of the dialogue But quite frankly, we want you to be part of the solutions, part of the actions, because words are cheap. We need to act, and we need to put things in force. And I encourage you, first of all, to stay tuned and to stay engaged with Livestrong, but also do me one other favor, okay? If our efforts seem hollow or our actions don't back up what we say, hold us accountable, because we need that. We all need to hold each other accountable to making progress. Otherwise, 5 years from now, we're going to be in this same spot. We're going to be in the same spot having said a bunch of really good stuff, but not really done anything. And it is really important for us to act and to put money and resources to address these issues. One final comment as I part. There is no one person who has the right answer. It takes a community engaged. It takes a community rising up together to identify solutions, the best solutions. And those can come from any one of you that are on the screen today, as well as your peers, your friends, your family, and your neighbors. I invite you to continue the dialogue, but I invite you to get engaged in identifying those solutions. We look forward to continuing to talk with you and share our ideas and thoughts. Thanks to Suzanne and Brittany and other members of our team for putting this on. Again, thanks Sharon, Lelia, and Rhonda for your participation. I look forward to us continuing to work together as we take aim at these gaps in care that are so critical. And as I described in my moral group earlier, this is not just a medical problem. This is a moral and ethical dilemma that we have to get through together. Thank you all for joining us today. Back to you, Suzanne.
Thank you all again so much. Thank you, Greg. And we can't wait to see you at the next ICON EQ. And again, you'll hear from us very shortly. Thanks again, and have a wonderful rest of your week.